upper right.
Hello, everybody. Today is July 11th, and we are the Board of Health convening at the County Admin Building. And it looks like a lot of people are here today, which is great. Welcome, everybody. Let's see, what do we have to do first?
I'd be curious, Greg, who is on, are we on the OWL? No, okay, so
Who's online? We'll see who's there.
They are online.
Got it.
I think we're expecting Krista and Barry to join
Excellent.
at a certain
When
point.
when the time comes. I see Brian. Already I see Kurt.
From the microphones, make sure the red light is on and speaking into the mic. Thank you so much.
Right. Thanks, Michaela. Yep. Make sure your red light's on if you want to talk. So we're calling this meeting to order. A roll call. Jordana, you've got a quorum.
We've got a quorum.
Who's not here? It'd be easier. Okay. Review of the agenda, corrections and approval of previous minutes. We'll have public comment, a communicable disease update, oral health program update, air quality and monitoring update, medical officers update, directors update. Then the round robin. This will be interesting. Medical, the director's update has something, I think I requested this, but maybe others have too, just regarding the Surgeon General's call for warning labels on social media. But back to approval of the previous minutes. Do I have a motion to approve?
So moved.
I'll second.
Okay, all in favor? Aye. No other conversation? Too late. Okay. We're going to go to public comment now. Is there anybody in the room or online who'd like to comment? *9 to raise your hand. I think that's still *9.
Did John second that?
He did. Yeah.
Is John as an alternate?
Oh, right. Oh, gosh. I need an official second. Okay, Linda seconds it. All in favor?
You're here, John.
Sorry.
We're glad you're here. Thank you for catching that. See, it's nice to have somebody flying right next to us. Wingman. We got a wingman.
This means I could leave.
Or you could lead. I could leave and you could just take it. Okay, where are we? We've approved the minutes. Public comment, *9 to raise your hand. I don't see anyone. I think we're gonna bring it right back and go into the communicable disease update. And Carly is
Not here.
not here yet. Well, what should we swap her with?
Dr. Levin, do you want
Yeah,
to start off with your?
Kim's here.
Oh, with mine?
Officer update?
Sure. I don't think it's quite as important as hers, but we can swap, no problem. We just bring it up here. Okay.
And thank you in advance, or not, thank you before you begin speaking for your op-ed on gun safety. Most
Thank
recently.
you. And I was actually wanted to start out with that, and I wanted to thank Katie and Jordana for June being Gun Safety Awareness Month and all of the communications around that. And it went really well with me having an op-ed and wrote about gun safety. And I hope everyone had the chance to read it. And it was nice to use yours as a template. And also for the future ones that are coming up, if anyone wants any help or how I did it, I'm happy to help out with any of that. But yeah, I just think I learned so much through this process, and the op-ed was, and it's so nice that this is working out with the Aspen Daily News. And it came in concert with this huge advisory that our Surgeon General put out on June 25th on that month. And so everything kind of came together. And I think the kind of interesting thing about it also is this debate about gun violence. This was the first big advisory that the Surgeon General put out about gun violence, defining it as a public health issue. And it's just interesting to look at that and see that, because we've never really looked at it before as in such a formal way. And I just wanted to talk about it a little bit more after the advisory. And I just thought it would be really worth it just to briefly look at the advisory, some of the things that were in it, and then some of the response to it, and then what we can do here locally. So what I did in the editorial was I really tried to lay out very specific things that we can do locally. I always think local change is the only way that we can act. We can learn about these huge issues and then act locally. And so that's what I did in the editorial. So hopefully it's it, you know, it helps out with everyone. And then also we did a talk that one of the police officers at Snowmass came in, and Jordana and Katie really helped out with this and did a gun safety talk at Pitkin County Library. Not well attended, but at least it put it out there and started the conversations, which I think are really important. So does anyone want me to go through kind of the main points that I did in my
Sure.
editorial? With that might even be more. I didn't do slides on this, but I was going to kind of go through this more, but let me see if I can pick that up, because I just thought it was what was more important locally. And then there was one response to it as well. So I started off saying, you know, this is such a huge issue. What can we do about it locally? And my first point was that safe storage is key. And there's really a lot of ways. This report comes out looking at the number of deaths from children is very high from unsafe storage. It's like over 50% of guns stored. There's more data on this. Are not stored safely, and that directly leads to gun violence, intentional or unintentional. And so safe storage is kind of a key, and there's locking mechanisms to guns. There's gun safes that can be purchased and should be purchased for homes, and then there's options for safe storage outside of a home. So those are all the gun safety storage. And every gun is sold in Colorado with a locking mechanism, but there's many guns around that don't have them and don't use them. And so that's kind of the bottom line in terms of how do we improve safety locally. And it's really getting the word out, providing free locks, these little trigger locks that the sheriff's office now has for free. The gun store in our valley, there's one in Basalt, and they provide that for free as well. Anyone can pick one up. So it's kind of trying to get these out into the hands of people who have guns and don't have them on there. And that could be the difference between life and death for somebody, especially a kid. So that was my first point. And you can pull this up at the Aspen Daily, in the Daily News, of course. So 54% of gun owners in the US have at least one unlocked or unsecured gun in the house. Pretty interesting. And that's really what leads to deaths. So the second point that I made was change the culture of conversations. And so this lies on everybody's lap, gun owners and non-gun owners, that we have to start talking about it. So parents who have kids going over to homes, ask the question, do you have guns? Are they locked? Like, make it a normal conversation, make it something that's not awkward. It's so awkward to say, my kid's going to your house. Is that, you know, do you guys have guns? Like, people will take that personally. There's just awkwardness around it. So to make that a norm and just kind of raise it to this changing the culture of the entire conversations is going to be key to actually creating safety. And that is not easy sometimes. And I think a lot of it is also in the hands of professionals. So healthcare professionals, mental health professionals, like asking the questions, having them as screening questions. Do you have a gun in the house? Do you have do you know how to lock it? Do you have a lock? Do you have a trigger lock? Do you have kids? Do you have somebody who might be mentally unstable in the house that you're concerned about? So these are the kind of conversations that will literally save lives. And then the last thing I talked about was the ERPO, so the Extreme Risk Protection Order. And this was something I wasn't really familiar with until, and I can't remember if I talked about it at the last Board of Health meeting at all. I did a little bit, yeah. So if we feel that we have a friend or a family member who is unstable and has suicidal thoughts and has access to a gun, that combination, you can actually get a court order to have the gun taken away in Colorado. And that's been more secured over the past year or so in the state. So I walked over to the courthouse and they have the paperwork there. They can help anyone who wants to fill it out. It literally is done within 12 hours. There's a statement, and then it's a court ordered, you know, removal of that firearm for the safety of that individual and people around the individual, but mostly for the safety of that individual. And Colorado has a very high suicide rate. And then that's good for 2 weeks. And then there's an expanded version of that as well. But at least for 2 weeks, people have some time to try to stabilize things. So that's called an ERPO. That's in Colorado. It is in effect. We can do it here. There haven't been any yet here in Pitkin County, but they are fully prepared to help out and do it here if needed, and are well aware of this law. And that is basically it. I wrote about a couple other things too. Yeah. Suicide makes up 76% of firearm deaths in Colorado. Children and unstable adults, and also just unintentional and not understanding safety. So anyway, these were just some of the things that I thought would be interesting and really useful locally. Anyone
Thanks.
have questions about that?
Yeah, thank you, Dr. Levin. Any questions or comments? I was just thinking about that op-ed and wondering if we should consider publishing maybe an ad with a checklist with, asking, hey, do you have guns? And just putting it front and center. So when somebody opens the paper, they see it
We did a lot of that
with an
during
ad. Yeah.
June for gun safety.
How come? Okay, you already done it. And I knew it was a good idea.
So there was a lot that went out on social media, in an attempt to get some of our partners, like the police department, to help bolster that messaging and push it out. So that was the first effort for this year. And if it's a topic that we pick up again next year,
Great.
we
Well-
can take from what we've learned and go from there.
My second suggestion was, do you think we should go back to the commissioners with maybe some sort of, could we institute a rule that any sale of a firearm must include a lock or a safe or
Already
It
part of
is a
Is it-
Colorado law.
it's required to offer it to them, but is it required to take it? Is it required to
When I called the Basalt,
carry it out of the store?
which is the only one in our valley, they said all firearms are sold with, it's like a little trigger lock. It's just a
Right.
little lock on it, by law.
Okay,
And that's what happened. here.
another brilliant
Great
idea.
You're on it, man. You are following in the footsteps of
Just-
giants.
Just a day late and a
And it was
dollar
actually
short.
so nice that the partnership with the sheriff and the police office locally was really great with this. They were very much behind and supportive of all of these points.
Great. Well, this is really great
Thank
news.
you.
Go ahead, John.
On a related note, I just saw this in today's news that vending machines have been installed in a handful of grocery stores in Texas, Oklahoma, and Alabama that sell bullets. Machines verify a buyer's identity and age by scanning their ID and confirming it through facial recognition software. The Texas-based company American Round says it plans to expand its bullet vending machines to other states with lax gun laws. So I don't think we have to worry about it here, but pretty crazy.
Well, yeah. Go ahead.
And you got to think people can,
It's hard to imagine that. And, this report came out on a Tuesday, which was right after the weekend in Alabama and Arkansas and Ohio, that there were mass shootings that weekend right before. And so it's just, there's always going to be the others, there's always going to be a side that doesn't agree with this. And there was a lot of support for this from physicians, from gun control organizations, from so many sides. And then there was a lot of resistance from gun rights organizations and from some politicians that felt that gun control is not a public health issue and that it's overstepping grounds and it's a criminal issue. And so it's a political and a criminal issue. And so it's just a really interesting definition because he came out with this and as a public health, issue. So there's always going to be this.
Crazy.
hasn't the national government been prevented from doing any studies on? I mean,
Studies on,
NIH.
yeah,
Right.
yeah.
Where the FDA couldn't opine on gun safety, isn't that correct? Or there was
Now, but the amount.
previously couldn't.
The dollars that go to them to do it is
That's-
extremely, very small.
Got it.
Dr. Kurt?
Yes, I'd like to comment that a lot of Texans do travel to Aspen. So because they're available in Texas, those people could be not necessarily flying here, but driving in the summer. And also it's the type of weapons that are available now. When I grew up, I went duck hunting with my father. So it was a kind of a father-son tutelage of respect. And now the assault rifles, these assault weapons that are available should not be on the market at all. It's crazy, crazy.
Yeah, I agree. Thank
That's a
you.
great point.
Okay, anything
Any
else? Oh, Linda.
If somebody, if like response, if they have women who are in abusive relationships, would they be, and they know that there's guns available to their partner who's abusive? If they, can they go and get an order for that person's guns?
That's
to be
such a great
taken away?
question. I was just reading, I think that went to the Supreme Court in June,
Oh.
actually, and I have to look at that. Yes, I mean, I think if there's any, does that fall under the ERPO? I don't know that that does, and it's a really good question. If you, I mean, I guess you can claim that that person is mentally unstable.
Yeah.
And I
put it
can't
under that.
recall, but the police department, when they were doing the training, they may have touched on this topic and I can't recall the answer.
Yeah.
But Todd Holler, I can reach out and see if he's got an
Okay,
answer for you.
Great. Thank you.
Great.
I would think that, I would hope that the answer is yes.
Yeah. Me too.
Yeah.
Well, thanks for that. I think we should move on, but
Okay.
unless
Yeah,
there's
you
more,
don't
but
have to
that's
go through
really
any of the other
helpful.
slides.
If I have any other good ideas, I'll let you know.
Yeah.
The report that John Doyle and I have met for our op-ed that's coming.
Oh, great.
with Respiratory viruses. We met in the Aspen Valley Hospital cafeteria,
Yeah.
went over the resources, communicated that to Jordana with the references from CDC. So we're going to do an update, which CDC will have available. And ACIP, the Advisory Committee for Immunization Practices for December. I'd like to do it a little bit earlier with fall viruses really being more September, but we're ready. We're ready.
Thank you.
Great.
Thank you.
Yeah, it'll be important. It'll be really good timing.
Yeah.
In December.
So I don't know if Carly's here, but we could go to Logan, who's come into the room. Carly is here. Oh,
I
pardon me,
am,
Cora.
if you want.
Hold on a second.
Dr. Tom, kind of, were you asking if it was possible to run the respiratory article sooner than December?
Yes.
Okay,
Well, I think we've had the conversation go around once already,
Okay.
but I don't know, do you?
I respect any decision.
Sure. Jordana, do you want to opine on that?
So the response was that we have quarterly columns with the Aspen Daily News.
yeah,
The next one will be in September, which is a mental health
Mhm.
topic, and then December will be our final one of the year. So the
Question, well,
yeah.
would it make sense to switch those two?
and I'm just out of deference. I mean,
thank you.
if we're saying that respiratory illness is in the fall is a better time, that's all I'm saying is if it's true that would be better to go ahead. I think this is good on a monthly basis myself. So,
That's the mental health.
Yeah.
Anyway,
It really should be monthly.
Well,
I just want to support. If the suggestion is
right,
that
thank you.
it should be
Let
moved,
me-
I just want to
Let me
support
just make a proposal. Would the mental health thing fly better just before the holidays? Or is it better that came out in September? If you were to choose which one to put up and you had a choice, you do have a choice, right?
I mean, September is even early. I mean.
The thing about September is I feel like there's not going to be a lot of data in September. We're going to know so much more in November and early December, like what the season's going to be.
Okay,
There's going to be data and I mean, I think September can be like an early warning of like, hey, this is what we're anticipating. This is what we think, the flu vaccine, how effective it might be based on the Southern Hemisphere. Like we might have a little heads up, but I don't think there's that's my personal
Yeah,
take.
in September, at that point, all the vaccines that are going to be available, the updated
You
version.
do, but like Moderna is working right now on an H5N1. Like it's just, I don't know that maybe not. I would.
I'll also say we chose to do it later in the season last year, so towards that October, November, December timeframe, to target a lot of our workers that come into the valley specifically during that timeframe, and acknowledging that September, October time is our off season, and so we miss a good portion of the population who would benefit from that messaging and knowing where to get those vaccines if we target it too early. So on top of the data concerns and not knowing quite when they'll be released, that was sort of our strategy when we thought about it last year, but happy to adjust if we believe it's beneficial.
Okay, well,
And Carly will certainly be putting out a lot in September as information comes out that, I mean, it's.
Okay.
are you,
Putting it
are
out.
your
Maybe
questions
they could
answered? Do
move
you
it a
feel
month
comfortable?
earlier.
We can always ask them.
Anything in December.
We can appeal to
Let's
the,
ask, when we started
red
the
paper.
conversation with the Daily News, they wanted a quarterly column to start with, see how it goes, see what the response is.
Thanksgiving. Before
They have
Thanksgiving.
very specific, their specifications of exactly when they want it and when they're going to print it.
right. You could always reach out and see if they've changed their, if they have any flexibility, but if not,
If
let's
the
just go
board-
with what
if
we've
the
got.
board Feels strongly about moving it up a month, we can do it.
We can ask.
We can ask, you're gonna get it in the paper earlier in November, but then you're going to be missing, like as Carly
Off
said.
season.
Right. I'd love to
Audience might be a little bit
propose
bigger in
that we
December.
leave this to Jordana to sort out with the paper. I really don't think we need the entire board to opine on when to do it. So I'd love to move us along, if that's okay.
Mhm.
But thank you for the conversation. We were wondering about that. Carly, since you're on deck, keep going.
I was going to say that was an excellent segue. Thank you, Dr. Kurt. All right, jumping in with a communicable disease update. Oh, I'm not quite sure why those are blue. Sorry, if that's incredibly difficult to read. Do want to touch on COVID-19 since we were just talking about it, and that a couple weeks ago I saw quite a bit of media attention being paid to the summer increase in COVID-19 cases, and so just wanted to touch on it here, even though what we are seeing is not surprising, even though what we are seeing has become relatively routine at this point. Do just want to make sure that we address it. So is COVID-19 here? Absolutely. This is a trend that we have seen over the last multiple seasons, where we are about 6 months out from that large infection wave over the winter, as well as 6 months out from that vaccination campaign in the winter. So not only is our immunity waning, but we're also seeing highly mutagenic impacts from this virus. We're seeing a litany of variants that are circulating currently, all of which are selecting for immune evasion. And so we're just seeing more and more people getting infected during this time. Secondary to this graph is wastewater data from the entire country. So I do want to highlight this is a very large population sample, so it's not specific to local, but that just wanted to highlight that, yes, we are seeing that increase, but that risk is not shared universally across the United States. We are seeing a little bit of increase in COVID-19 locally due to some of those summer events like Food and Wine and July 4th, but a good portion of increases occurring in the southern United States and in states that are being impacted by that heat wave that's occurring. So it's changing human behavior, encouraging indoor socialization, et cetera, et cetera. So is COVID-19 occurring? Yes. Are we likely going to continue to see increases over the summer? Yes. Is this new and concerning? No. Currently, severity indicators are not showing any massive increases. Yes, they are increasing with the rate of increase of COVID-19, but nothing super alarming at this time. So do want to highlight that this is occurring. The media was paying a lot of attention to this a few weeks ago, but this is not sending up massive red flags, for me at least, and for a vast majority of other public health. Any sort of questions on specific to COVID-19?
Thanks, Carly. That was quick.
That was quick. I know. Trying to.
I don't see any hands up. Let's keep going. Oh, we got a hand up.
Is
Dr.
wastewater
Kirk.
being monitored in Aspen now?
Yes, and you beat me to the punch. We do have a whole wastewater slide.
Yeah, that's the United States, right?
She said yes.
Yeah.
Yes.
You've got a chart to show us?
I do.
Oh, well, cut to the chase here. What, we are all waiting for it.
Again, I am so sorry. We could skip to wastewater, but I do want to touch on this real quick.
Teasing you.
And again, I'm not
Okay.
quite sure how we got half and half color here. My bad. But do want to touch on HPAI, H5N1, cow flu, influenza A. It has 10 different names that are circulating right now. And just highlight that this is something that is impacting the state pretty heavily and not necessarily impacting Pitkin County specific, but wanted to talk on what we're doing to track this, how we're responding to it, and how we're working with the state and local partners to make sure that we are paying attention to this. So just want to highlight that a vast majority of these infections are occurring in cattle, particularly dairy cows, and particularly in the northeast side of the state where a lot of those commercial dairy products are produced. And so within 2 weeks, we as a state have gone from 3 to over 20 dairy facilities being impacted, which is quite a substantial increase, and there's no current sign of it slowing down. So this is here, this is around. not necessarily in our neck of the woods, but it is circulating and it's something the state is taking quite seriously. This comes on the back of the first human case in the state was reported from July 3rd. And so mild symptoms, it was respiratory, but it was mild and it occurred in a high risk dairy worker. So they were likely exposed at work. They got treatment that they needed. They were in isolation. They cleared the infection. Everything looked good so far. And there was no secondary infection from that case, which is good to hear. That being said, the more opportunities this virus has to make its way into human populations, the riskier it can become. So a lot of effort is being done around preventing that spread from cattle or poultry into human populations. So in general, the risk to the public is incredibly low. So I do not want to ring all the alarm bells. The general population is safe. That being said, there are ways to avoid potentially coming into contact with this. So in general, one of the big ones locally is avoiding all unpasteurized dairy products. That includes milk, that includes cheeses. Individuals who are in those milk share programs are hopefully paying attention to this. We're trying to work our way into that. And just being aware that there is a substantial risk from unpasteurized dairy products. General individuals can avoid contact with ill poultry or cattle. So if anyone has backyard poultry stocks that they notice are experiencing severe illness, anyone's coming face to face with cattle that they believe may be ill, you can go ahead and report that directly to the USDA, who will help perform any sort of testing that is required. And that testing in the state of Colorado is available for individuals who may have contracted H5N1. Dr. Levin is here. We just had an excellent conversation yesterday about this, and that all PCR positive influenza A's may be sent to the state lab for sequencing for H5N1. And so since Aspen Valley Hospital runs a vast majority of our PCR influenza tests, they are likely going to be the ones spearheading this. But again, influenza rates right now across the country as well as locally are low, including influenza A. There have not been any major alarm bells in influenza surveillance in wastewater anywhere across the country, which is nice to know. And we're not seeing huge rates of increase in influenza A anywhere in the country, even in areas where dairy and poultry farms are highly impacted by this virus. So right now it is still having a hard time making its way into humans. There have been no secondary human-to-human transmission that's been recorded, and that one of the best ways that we can encourage individuals who might be working face-to-face with potentially impacted animals is to increase utilization of PPE and other biosecurity measures on the farm or the dairy where that is occurring. So all of that messaging has been sent out to these facilities that are at risk. So they have all this information, they have all these resources. PPE is available for them to order for free through the state. And ultimately, Colorado, I think, is doing a fairly good job at this response and trying to pay attention to it, knowing that there are multiple parties between CDPHE, USDA. There's a lot of large organizations that play a hand in tracking this throughout the country. This is a very brief introduction and just sort of a highlight of what's been happening and what we are doing about it and paying attention to it. The CDC is also holding a COCA call next Tuesday on July 16th. Registration is open, and that they will go much more in depth into the situation as a country, as well as what the CDC is doing to prevent the spread of this on a much larger scale.
Carly, can you reassure us that that our love of French cheese and Aspen crud isn't going to be affected by this?
If I cannot, if those are
well,
unpasteurized dairy
reassuring.
products, no, pasteurization is still incredibly effective. So general cheese, general dairy, all of that is 100% safe. That being said, unpasteurized products, we should be keeping a very close eye on and assessing our own risk for if we want to choose to ingest that at this time.
Thank you for that. What's next?
Next is wastewater.
Okay. John brings up bird flu. I don't know if you've got bird flu in there.
That was what that one was. I'm so sorry. I should have
That was
added that
bird- oh, it
into
said
its
cow flu.
10,000 titles. I know.
Okay,
That
but
one
it
was
is-
bird flu.
The news article John just showed me said a state of emergency. What does that mean when Colorado declares a state of emergency? Is that what you were talking about that, and that was the state of emergency declaration?
Yeah, so the state of emergency, and again, I am glad to be in a state where our governor is taking this quite seriously. There are other areas in the country that are less so. State of emergency specifically, it's similar. I don't want to call it COVID because it is not. So it is not COVID. But that state of emergency allows the state to utilize resources and funds in a much more dynamic and flexible way in order to respond to this particular pathogen. So even though this is not a human health concern at this time, even though the risk to human populations are quite low. This could impact our agricultural sector. This is impacting our poultry sector and our egg production, and all of that resource that is now released and being able to be utilized by the state to prevent that spread from those sectors into the human population. That's a very brief
Thank you for that.
understanding of it.
Okay, now to wastewater, what you've been
Yes.
trying to get to. Thank you.
No, you guys are you're on it. You know what I'm going to talk about. And so
I'm sorry, we got a
for-
question before you move on. Sorry.
Not a
course.
question. I just wanted to add, there were 1.78 million chickens put down on
Yes.
Tuesday because of this.
Yep.
It's a lot of birds.
Okay. Yeah. Okay, back to you, Carly.
It is. I know. We're watching HPAI, we're watching avian flu, cow flu, all that. We're watching it closely. Which beneficially, the state is also utilizing our wastewater system to be able to track avian flu in our wastewater system, which is good to hear. So just want to highlight that there are going to be incoming changes to the Colorado wastewater surveillance system. Prior to this, there were roughly 55, if I remember my very strict numbers correctly, sites that were brought online in order to respond to COVID-19. Come August 1st, they are going to reduce the number of sites that are routinely submitting data to CDPHE down to 20. And so those 20 sites, 10 of which, and those are going to be called Sentinel sites. So that map that's on that right-hand side, if you're thinking about the difference between the two, Sentinel sites are the ones that will continue to supply data twice a week to CDPHE as routine surveillance systems. 10 of those sites were selected to represent the regions in which they are found. While we had 55 sites that were operational, those sites statistically very well correlated to that entire region's trend. So they chose a site that not only covers large population hubs, but also represented well the entire region that they are part of. So 10 of those sites are that. A few of those sites are going to be in the Denver metro area because even though that's one region, it is broken up into various populations and wastewater treatment facilities, and obviously acknowledging that that's our largest population hub. And then the other choices are in tourism areas. So I think there's 3 sites in Denver and then 7 high tourism sites. Aspen was selected as one of those high tourism representations. We recognize that those high tourism areas don't always follow the trends that are visible in those regions. Pitkin County was first to identify some of the Omicron variants. We're first to sort of see some of these really big upticks in activity. And that goes across the board for a lot of our tourism areas in the state. So Aspen was selected as a Sentinel site. So we will continue to receive bi-weekly data updates from the state lab for our wastewater surveillance, which is incredibly exciting. I'm really glad that that happened. There was a lot of advocacy that went into that. I'm not sure if this group or anyone here had any hand in that, but I'm so grateful to you if you did. And the other site that was selected was Glenwood. So we're going to have a nice bracket to be able to see a glimpse into the wastewater data for our community. Just want to highlight that this is a reduction, so I don't want to gloss that over. With the 55 sites, this did cover 65% of Colorado's population. With the current 20, it covers about 50, so right at that 48% mark. So it is a reduction in coverage, but again, these were chosen because they statistically correlate with the areas and the regions where they are selected for. The goal for this, why we are reducing, is that there has been quite a change in the funding allocation for COVID-19 surveillance, and that this is one of those pieces. And so they've chosen to reduce the number of sites that they're analyzing samples for on the regular in favor of expanding those potential targets. So no longer, or hopefully in the future, we're hopefully looking at data that's not just COVID-19 specific, but looking at statewide data for RSV, for influenza, for all these other possibilities that could be utilized for wastewater surveillance. So it is a shame to see a reduction in sites, but it's really exciting to think about what comes next. What are those new targets that we're going to have access to, and what is that data going to look like? The other side of this is that there are emergency surveillance sites. So a lot of the sites that were closed down for that routine sampling are being maintained as that emergency surveillance location. That means that these have signed agreements with the state to be called upon should an emergency health crisis occur. And so why I talked about HPAI is that this has been utilized in that northeastern part of the state. They've stood up some of these emergency surveillance sites in areas where HPAI and avian influenza is occurring in order to best track influenza A in those areas. So they were able to set up these systems, get these samples submitted all within the span of about 10 days, which when we're thinking about public health crises and trying to monitor a population, that's an incredibly fast timeline and really exciting that they were able to utilize this tool in this sort of emerging space. So it's coming. It's happening August 1st. We will continue to see Aspen wastewater data, but for a lot of the state, it is going to change how we understand wastewater data.
Thanks, Carly. I'm looking at the clock. Are you finished or I
That
think
was
we
it.
started late, but is that it? Is that everything you've got?
That was
That's all
done.
you got?
I just
Wow.
have one comment on that.
Yeah, go
That
ahead.
was great. Thanks, Carly. And just to reiterate that it is a very low risk to the public right now, H5N1. The one case in Colorado was conjunctivitis and the patient did get antivirals and did really well with it. However, I think the question about the raw milk is really interesting and pertinent. And I looked into it a little bit. So the state of Colorado, it's against the law. It's prohibited to sell raw milk in the state of Colorado unless you're under these milk share programs. So out of farm. So it's like a CSA program for milk. And so if you are, so you're basically buying into owning part of a cow, I guess, to be able to have that. So there is raw milk that's legally sold through these programs throughout the state. And that I see would be potentially the source of if there were, because it's so specific, the risk factors are so specific. You really have to have interaction. You have to be working on a direct contact with a cow that's infected or a bird. And so for a lot of us, we don't have those risk factors. It's very low for us and for the general public. But that's just one thing to know about and look out for. So pasteurized milk products are safe. And then raw milk products, which there is definitely in the state of Colorado and in this valley. At this point, with this type of emergence that's happening is not a good idea.
Right. Thank you. Liz,
What about chicken and eggs?
which came first?
Well, I mean, are eggs considered safe and chickens?
Yes, eggs and chickens are considered safe. Of course, they should be cooked. You have all the other health concerns with raw chicken and eggs. But because it's respiratory, and because it's specifically located in the udders of these dairy cows, chicken products that are on the market are safe. Just cook them, please.
Thank you.
Good question. Thank you. Okay. Thanks, Carly. That was, as usual, you packed about an hour and a half worth of stuff into 15 minutes, which is remarkable.
News announcer.
Y'all make it easy.
Yeah, I know. Yeah, you should be, you could call horse races or the Tour de France,
Auctioneer.
auctioneer.
Auctioneer, that'll be next. That'll after
Okay.
HBA.
So if Logan and Lisa, come on down. We've got seats for you. Thanks for coming. Great to see you again.
Afternoon. Am I looking at you to move slides? Great, thank you. Hello, everyone. Can you hear me okay? Hi.
Yep,
I'm
is there a
Logan.
red light on,
Oh.
just double checking.
Yeah. there
Okay, you're
is.
good. Thanks.
It's just red in the light. Good afternoon. My name is Logan Hood. I'm the Executive Director of Community Health Services. Great to see all of you here. And with me today is Lisa Westhoff, our Regional Oral Health Specialist who oversees, she's the manager of the program we're going to be talking about today. I'll just look at you. Just for those that might need a refresher about who and what community health does. Community Health Services is a safety net nonprofit health clinic. We've been around since 1971, almost as long as Linda's been. I'm kidding. Linda's been with us for a really long time. But we provide reproductive health, immunizations, prenatal care, family planning, including STI testing and treatment. We are a partner with WIC, Women, Infants, and Children. We're contracted with Pitkin County Public Health to help to support communicable disease surveillance. And we do breast and cervical cancer screenings. Our purpose, we believe in access to affordable and preventive health, that it's essential to the well-being of the Roaring Fork Valley and the overall health of our community. Just in the last few years, we did a strategic plan and we came up the board with 3 values that we're grounded in our work, and that's equity. Everyone has a fair and just opportunity to achieve optimal health, advancing best practices in preventive community health, and accessibility. A real cornerstone is the quality and compassionate and confidential care that we provide that's affordable, understood, and usable by our diverse patient population. We are located at the Health and Human Service Building, just across from Aspen Valley Hospital. And we're grateful to have that clinical space in kind by Health and Human Services. It wouldn't be possible to have our exam rooms without that support. So thank you for that. Go ahead and move on. I wanted to give a little summary of the programs because one of the ones we're talking about is one of our newer programs since 2018. It's not that new, but it's newer to our menu of services that we've provided for many, many decades. And that's our dental oral health program. It really is a piece of CDPHE's oral health unit. And that is they're a department at the Colorado Department of Public Health and Environment. They promote oral health equity by preventing oral health disease and enabling access to oral health care to ensure that everyone in Colorado can get the care they need to have the highest level of health possible. Just focusing on oral health here. They operate to provide funding to 4 rural regional oral health specialists in the state, which is housed in a local public health agency. And Lisa is one of 4 of our regional oral health representatives in the state to support and implement oral public health initiatives such as school-based sealants, water fluoridation, coalition building, cavity-free at 3, try to say that 3 times fast, trainings, and other oral health access programs and evidence-based oral health and chronic disease prevention initiatives. So the regional oral health specialists, which is called the ROW, we just kind of shorten it, we call it the ROW, those 4 cover actually 20 counties in the state, more of the rural counties representing some of Colorado's most underserved populations. Our ROW, Lisa, has been with us when we took on the program in 2018 as a program with Garfield County Public Health and Community Health. But the program itself, the work we were doing in Western Colorado was from 2008. So Lisa, like I said, is one of 4 regional oral health specialists and representing really Western Colorado. And Garfield County Public Health and Community Health partner through funding and collaboration and all the things we do to make this work happen to provide direct services, education and advocacy, improving oral health across Aspen to Parachute. So I'm going to have Lisa kind of get into what those programs include that we're doing and have been doing through our partnership with the Oral Health Unit at CDPHE.
Great. Lisa, welcome. And where are you based? Where do you live?
So I'm a licensed dental hygienist by trade and education. I grew up in rural Colorado, but way out on the Eastern Plains by Kansas and Oklahoma. I've lived in Western Colorado for, over 15 years since graduating from my initial dental hygiene education. And I live in Grand Junction, but then I get to travel the Western Slope. So because Parachute, I cover all the way, like she said, from Parachute to Aspen. So I get to come all the way up here to beautiful Aspen and spend a lot of time in Rifle. Like this morning, I stopped in Rifle, Glenwood, Elgibel, and then Aspen on my way up. So, and then on my way back, I'll probably make a couple stops on my way home too. I'm always picking up and dropping off items on my way to and from, because we do have a lot of different locations that we serve. And summer is actually a little bit slower because we have no schools to cover this time of year. But we do cover a lot of different parts of our rural area and the Western Slope. So yes, I am in Grand Junction, but I'm really fortunate because with my job, I can do some remote and all the mobile work that I get to do. So lots of traveling, which is wonderful.
Great.
Yeah. But our first part here with talking, kind of getting into our oral health portion of all of the work that we do with CHS and the 3 counties really talks about some of our oral health priorities. I'm not going to read all of them to everyone, But when you look at these, you're going to see that it's not just focused on like the physical, like clinical services that we're providing to clients in the community, which we do a lot of that. And we're going to talk about a few of those things because those are the fun things that we get to do. But there's lots of other things like policy, and we're working on accessibility and increasing access and trying to get patients to dental homes. That's really one of our big main goals. It's the hardest goal that we're working on all the time because I'm not trying to be the patients and the community's provider. My goal is not to be their dental hygienist or to try to replace their dentist. I'm trying to lift them up and bring them to a dental home that can be their actual dental home. I'm that stopgap that's trying to help them. Me and a whole team of other dental hygienists and individuals that are there to help them. So, you know, that's what I'm always trying to help sometimes our dental community understand too. I'm not trying to replace them. I'm trying to get people to them. But sometimes I need their help too. So you'll see there's always a lot of education, and we have a really big focus on prevention with our programs. So we have a big focus on kids in a lot of our things. Go to the next one. So these are really some of our 4 like main, like really service focused programs that we have. We have Smiles for Seniors. This is the only program that we have that actually has a fee attached to any of the services that we offer. It is a very low cost program. At the highest end, we asked for $85 from our seniors, and we provide the most part is dental cleanings or therapeutic debridements that we do for seniors. We don't do x-rays. We do dental hygiene examinations. We do fluoride varnishes to help prevent decay. We do silver diamine fluoride, which if we want to talk about that at another time, I could spend a whole afternoon telling you all about silver diamine fluoride and how amazing it is. And you'll hear me say that many times. But we really keep that very low cost so that seniors can be able to afford fillings and crowns and dentures and extractions and other things that they may need to help support their oral health outside of what we can offer them. Pitkin County very generously also offers to support seniors that even $85 is too much of a financial burden for them. And they help support our program by supplying seniors that qualify a $50 discount. So then seniors only have to pay $35. We also are not in the realm of turning people away. And if a senior tells us they can't pay anything, you know, we will still see them too. That rarely happens, but we are not in the business of turning people away. You know, we will work with them at any level that they're at. Then we do have our Bright Start Smiles program, which is really focused on pregnant people particularly, and very small children that aren't in school yet. We do see pregnant people that aren't necessarily pregnant. They may be in kind of the pregnant time of their life. So more perinatal. They're in that time when they could be pregnant. So usually if they have children that are in that age of 0 to 6, they qualify for this program. And again, we're doing very similar types of care that we are doing for our Smiles for Seniors program. We do lots of referrals also whenever we're seeing patients in our Smiles for Seniors, but especially for our Bright Start Smiles patients, because they usually do not have a dental home. It has been a long period of time. They may be new to the area. They may have not been to a dentist in a very long period of time, and they often have more significant dental needs. And so we are often in sometimes more emergency states for them. And so we're trying to get them in to see a dental home much more rapidly. So teleoral health is a program that really evolved and we created during COVID, because it initially came from a time when we couldn't get into schools. Students weren't in schools, so we couldn't go see them during our Smiles for Students program because we couldn't get into the schools. No one was there. Then even when students were getting back into the schools were really hesitant to have just a big group of us show up and be like, oh, by the way, open your mouths. You aren't wanting us to spread any diseases, but we just want to get into your mouths where everything comes from. So we started seeing kids virtually to at least be able to provide education, talk to them about their brushing habits, their flossing habits, what they're eating, what they're drinking, their nutrition and diets and things. And it was a really fun program because kids will tell you all kinds of things. They'll walk you around their house when they get a hold of their parents' cell phone, and they'll show you what they're making for lunch. They'll, you start to see a lot of dynamics that are going on. That program has really become a staple for us and has shifted a little bit and is a little more focused on our adults now. So it has become a little more of our entry for our Bright Start Smiles. So we get referrals a lot of times from WIC. And so usually we set up a teleoral health appointment. And that gives us a good introduction to those new patients. And then we can also, if they have an emergency, we can get them a referral right away before we are able to see them in person. So we make sure we can start that emergency type of process right away. And then we can take care of their preventive things so that they're not having to spend money on those types of care either. And then we have our Smiles for Students program, which is where we go into the schools and we see students. Our big focus there is caries prevention. And then silver diamine fluoride helps us do a little bit of early treatment of caries also, because SDF can do some early treatment. It's a first step in caries treatment. They still need to see their dentist to get the final treatment done for those types of things. But it does give us a new tool and medicine to help with some of that, especially for some students that maybe don't have a dental home or maybe be in a transition where maybe they're moving and may not be able to get to see a dentist. So that may be the treatment that they're going to be able to get. So those are a very quick, a rapid explanation of some of our programs. But those are kind of our four like actual getting in and doing things in people's mouths.
Got it. Great. Describe silver something.
Silver diamine fluoride.
Diamine?
Yes. Yeah.
Okay.
At the end, I'll answer some questions too on
Okay.
that.
Oh, you're not.
Yeah,
ready
we're
for
in
that yet.
between.
Oh, okay. Keep going.
So I'll give you some numbers on a few of some of our programs we've done. So outside of those 4 programs, I also go in and do just screenings. Screenings are pretty like quick and fast. We're looking really quick to see, do you need to see a dentist? Like, what are things looking at? So we run our numbers and data run from August 1st to September 31st. We kind of run like a school calendar almost. That's just how the state runs us. And it works out okay with our school program. So far, we're not quite through with our Q4 yet, but we've done 338 screenings. Most of those are pre-K, Head Start, and elementary. Of those 338, 163 of those were actually at Aspen Elementary. Worked with Tony up there and we hammered those out in like a day and a half. We were rocking and rolling and got to spend some time up there. And so we really targeted like a couple of the kindergarten and 3rd graders, because those are kind of key ages for tooth eruption. So we targeted a few of those and were able to make sure that we weren't missing kids that maybe really needed to make sure they were getting in to see a dentist if there were key things going on. But those are outside of like our typical programs. And we work with Head Start too, because Head Start has requirements that students are receiving oral screenings. So think of those kind of like hearing and vision screenings that kids get in school. They're meant to help try to grab kids, that maybe have gotten missed with their, regular doctor visits if they haven't gotten those. So that was a value of about, I think if you hit the next button, it should, Oh, that's okay. That was around like, I think, like, had we like billed for those screenings, that was a value of care around like $12,000 of those 338. And of course, we don't, we're not collecting those kinds of things. We're not billing for those. So our Smiles for Students is by far our biggest program. We go into 16 schools throughout the school year. We actually did 17 this year because we did go into one high school as a pilot program. High schoolers are a whole other realm. We learned very quickly. I saw 6 kids. I shouldn't call them kids. They have adult problems. We thought we were going to spend like an hour. We were like, oh, 6 kids. We spent 7 minutes with our elementary and middle school kids because we are like in there. We don't want to take a lot of their time. They're doing a lot of things in school. I spent the whole day there with the high schooler kids. They have adult problems. They have adult questions. They want to talk to you about everything. Elementary and middle school kids are like, get me in, get me out. I don't want to be here. Middle school kids, especially, they're like, don't tell anyone I was here. So in the schools, we aren't doing cleanings. Our focus really is caries prevention and caries detection because dental decay is the #1 disease in children. Not #1 oral disease, #1 preventable disease. This is nationally, this is worldwide. So that's why dental decay prevention is one of our biggest focuses. So we saw 1,070 kids this year. We used SDF in a preventive and arresting, which is a treatment form this year. And we did that on 1,335 teeth. That was 787 kids. Because, we do have ask for permission for that from parents. We did apply 1,157 dental sealants. We did find 1,061 which one? Dental sealants?
Is that
Teeth.
individual teeth? So
Individual
1,000
teeth.
So divide that by what, 24, 28? Okay, just checking.
Yes. So teeth. So some teeth had dental sealants. Some we don't apply sealants on teeth that have cavities. Yes, so it gets, it's complicated. I could give you the whole breakdown of
No, no,
like,
just
yeah.
trying to get a
I
sense
got
of
pages of data.
Yeah, great. Thank you.
We did find, let me find my number of teeth. We did have 699 kids said that they had seen a dentist. That was asking the kids themselves. So that number I'm not 100% confident on this year because it got missed on our permission slip. So it was asking children. So, you don't always know if they're telling you the truth. We get interesting feedback from them sometimes. They do tell you good stories though. But we did find 1,061 cavities. So just generally teeth with decay. That's back and front teeth. And then we categorize them by risk levels and things like that and urgency. And we send a report to the school nurses that breaks down all the children so that they know the kids that they need to follow up with very closely. And because we've been doing this since 2008, we do have a very great working relationship with the schools, which is amazing. And so we have a lot of communication with them to make sure that kids are being followed up with. And so with that program, we're like, if you were going in and getting this care at a dental office, with that many kids, that's like $230,000 worth of care. And again, we're not doing cleanings or anything like that.
Okay, what's
yeah,
next?
Go next. Yeah, there we go. It did it that time. So for your silver diamine fluoride, this is a tooth with a cavity. This is an early cavity. This is a perfect example of a tooth that we can apply SDF to, that we can actually start the treatment phase of a cavity. And then the child can go see their dentist. They can have the cavity filled. They can watch that and see what's going to happen with it. This is an adult molar. You can hit the next button. So SDF is going to help us prevent something like this, which is going to lead to severe disease. Now, this is a baby tooth, but a baby tooth is very important. This is a molar in a child that's in elementary school, but baby molars should be in the mouth until you're 12 or 14 years old. You get that tooth at latest when you're 2. So you need that tooth for 10 to 12 years. Like you need that tooth for a really long time, and it's going to be hanging out with all your baby teeth too. So if it's hanging out and it's full of disease, it's going to make other teeth sick too. So this is why like what we're doing is really important. We use SDF on our adult patients a lot too.
Lisa, could you just briefly say what SDF does to the tooth?
Yeah.
Remineralizing.
So
Just-
SDF actually remineralizes or rehardens the tooth. So it can treat the cavity. Now, the bigger the cavity, then it's going to need more other dental treatment. It's not always going to be the only solution to the cavity, but it can at least be the first step. It can also prevent cavities at a similar rate that dental sealants can. It's just invisible. If the tooth is healthy, you're not going to see it, but it can absorb into the tooth and make it even harder. Teeth are extremely hard, but silver diamine fluoride can make it even harder. So it actually is going to reharden that cavity. It's still going to look like a cavity. It's still going to look dark, but it's not going to be gushy. Like if you've ever had a cavity, it's sticky and tacky and squishy feeling. The SDF, the combination of the silver ion and the fluoride, is going to harden it back up
and stop it from
and
spreading.
stop it from spreading.
Stop
Yeah. And it actually will help kill the bacteria that causes the cavity. Yeah. So it stops the disease process. It's one of my favorite things in the world.
And it's very inexpensive to use.
And it is very inexpensive. It's a liquid, it's 5 cents a drop. So I can do like amazing things for like next to nothing.
Amazing.
Yeah. So these are our numbers for just our mobile and telehealth dental clinics. So our mobile clinics are all of our adult clinics, the seniors, and our perinatal, our Bright Start Smiles clinics, and then our telehealth. So far we've done 239 appointments. We've done 106 for our teleoral health. We do those in the evenings. We've done 62 senior clinics, 71 prenatal clinics. Of those appointments, 162 of our patients have reported that they have no insurance. 30 of those of our patients also said they aren't sure if they have insurance. So that's a high percentage of our clients, our patients that have no insurance at all, and that's why we see them. Of those patients, we did 53 of those patients, we did SDF on them, and 332 of those 53 patients, 332 teeth, we treated cavities with silver diamine fluoride. So you can see too, especially in our adult population, we're treating a lot of decay. But that also is because some of our patients have gone years without receiving any dental care. And so they have multiple dental cavities going on. And so we're trying to at least get them semi-stable before we lift them up and we try to get them to a dental home so that they can try to then start the process of actually, really fixing and correcting some of their oral health problems.
Let's clarify, dental
Yeah.
home is a term I've never heard before.
So dental home is a term we use of like a dentist, or a dental clinic. We use the term dental home because there's lots of different places, like Mountain Family Health could be a dental home. A private dental practice could be a dental home.
Pediatric
Dentist could be a dental home. A dental hygiene practice could be a dental home. So part of that too is that I'm not trying to be their dental home. I don't want to be their dental provider. I'm the dental helper. It's more what I'm trying to be. Yeah.
Great. Thank you for that.
It's a research term too. Yeah.
Do you have a list of dentists that would work with people that are, financially challenged? And
Yes.
could at a reduced rate?
So we refer to Mountain Family the most. One, because I know for certain that they accept adult Medicaid. That is our biggest barrier for our adult patients that even have Medicaid. Adult Medicaid is very lacking in our for our providers in all 3 counties. I do have patients that will drive all the way to Grand Junction for care because there are more private dental practices that accept Medicaid for adults. Pediatric dental offices are more likely to accept Medicaid. But once you pass the age of 18 at a maximum, sometimes that age is lower, then you can't go to a pediatric office anymore. And then Medicaid or Mountain Family Health also does sliding fee scale. So if patients do not have Medicaid or private insurance, they can provide some assistance there. They also can help them see if they qualify for any other alternative programs like Medicaid. And they offer payment plans. It is really uncommon for dental practices to offer payment options. So you either pay up front or you don't receive care. And so that didn't used to be like that years and years ago. When I got out of school 15 plus years ago, that was really common practice to be able to work out a payment plan to pay off your dental bills. But that is just, it's just not really done anymore. And
Yeah,
so
it's
that
very
is,
limited.
that is really a challenge for a lot of patients on, lots of financial levels. So Mountain Family does offer payment plans for patients. So then that way they can at least, be able to take care of those things and work those out. Yeah. So we utilize them a lot.
Next slide.
Great, thank
Yeah.
you.
So I know we're getting close on time.
Questions too.
Is
So
there
I didn't know if there was,
questions,
yeah,
comments? Great to hear about this. Go ahead.
yeah.
I just had a question when you said there's 4 of your positions throughout the state and most of them oversee an area of like 20 counties.
20 total. The row covers about 20 rural counties. All 4 of them at least take a section of the
Mhm.
state.
So it's just the 3 counties.
Yeah, for our
Yeah.
side, it's.
So
the
I
people.
cover from over here, we have the 3 counties.
Mhm.
And how that all the rows have been in like all of the kind of areas were formed around the same time, as far as I know historically. So around like 2008 was when those were developed, and they've stayed like similar boundaries since. And most of that is funding kind of levels from the state as to why they've stayed. I know they would love to expand them, but
Well,
or
also-
even add to them and have additional
I think it
individuals.
also has to be what public health agency wants to take it under their
Mhm.
programming. So
Yeah.
right now they have 4 in the state that take it on, and Garfield County is the one that we partner with to do
Yeah.
the work. But we also, have funding from Delta Dental Foundation of Colorado, the Healthy Community Fund. There's a portion of that goes toward this work,
Mhm.
and our other partners to make it possible so that we're able to go to all those schools.
And we do bill, so for our programs, we do bill Medicaid for services provided if an individual has Medicaid coverage. So like in our school program, we do bill Medicaid if a student has Medicaid. We don't turn anyone away if they don't. We don't bill private insurance because it's complicated and there's no way for us to know, like for Medicaid, we can get into the system and look them up. There's no system to just look somebody up on their private insurance. And we also know what we should and shouldn't bill, so we don't mess somebody's benefits up. So we are very particular. There are certain things that we just don't bill for because we don't want to impact their ability to go see their dentist or their dental hygienist and receive their care. So we're very careful about like how we go about receiving, like supporting our program so that we don't negatively impact the care they can get somewhere else. We're very aware of that.
Does the bottled water you buy in the grocery store contain fluoride?
It does not. There is a type of bottled water out there called it's like it's like a prenatal kind of like baby bottle
Yeah.
water. It's very, very hard to
But in
find.
general, what you buy in the grocery store,
Right.
including these soft drinks, probably doesn't contain.
No,
fluoride.
they do not. Now Pitkin County's water does, Snowmass Waters does, Rifles does not,
Carbondale does not.
Carbondale doesn't.
Mm-mm.
And it most likely if you were on well water, it does not. However, there is a chance if you drink well water or like raw water that's not
Treated. or-
treated,
Mhm.
that you should test your water because you could have elevated levels of fluoride that can be dangerous for your health.
I was going to ask that question because I think that there's a historical information about Colorado having certain areas with fluoridosis. Is that what it's
Yes,
called?
yes. Yeah. So Colorado Springs is historically an area where actually fluoride was one of the locations that it was discovered. Its effects on caries reduction, like its effects, but it was Colorado brown stain is what it's referred to as. But at high levels, it can be not good for the health. Like, and it doesn't take that high of levels. Like the recommended level is 0.7 parts per million or 7 milliliters per liter. And once you get to 2, you're in 2 parts per million, you're in levels where you don't want to be. And if you're at 4, they call it bone pain level
Mhm.
of fluoride.
Wow.
So you don't want to be in that level. Yeah. And there are, and so and it can fluctuate too. Like if you're on well water,
Mhm. Based on
that
your-
can fluctuate. I'm assuming, based on like ground swells, like just,
Aquifers.
yeah, how the aquifer changes. So it's a natural mineral. It's in the ground. So
I did want to add how proud I am. Lisa has taken on this role just in a year and has done so much really innovative and really looking at the way we're delivering our programs and trying to be efficient and cost effective to reach more kids. And even integrating it just this last year, oral cancer screenings. We've added even a screening to our STI menu, sexually transmitted infection menu for oral HPV. It's a swab, simple, we could do whilst, talking about oral cancer. In addition to doing healthy beverage campaigns, cross multiplying with other local public health agencies, wherever we can, and HPV vaccines within the schools. I mean, we're trying to integrate a lot of the other work that we're doing in the dental because it is part of public health. I think often oral health, it gets to the side and we kind of forget about it, but it impacts so much of our chronic diseases and so many other things. It can prevent infection and keeping kids in school that don't have pain. There's a
Mhm.
lot of reasons why oral health is so important that I just appreciate the opportunity to talk about it because
yeah.
we're passionate about it and it's one of our many programs, but it doesn't get maybe the face time that it deserves. So thanks, Liz, for bringing it up because
Yeah.
it is something we're really working hard at expanding, collaborating, and just trying to see as many kids as we can. I mean, people.
Yeah.
We're not getting to everybody, but we're getting to those most, I would say, vulnerable, the most underserved. And really, like you saw some of those pictures, preventing some real serious problems and cost to the person and their family.
Great.
So-
Well, thank you for that.
Yeah.
Thanks glad we got you some
Yeah.
airtime. Liz.
I just want to thank them for coming. Was involved in this work most of my career with community health services, and I'm just so proud of Logan and Lisa for continuing it. And like she said, the innovation and the creativity that this requires is immense. And it really.
I welcome you to come hang out with me anytime.
Come see it.
Well,
I'll be in Glenwood Springs tomorrow at the Public Health Building.
So thank you for coming. I think
Yeah,
it's
thanks.
so
Thanks,
important
Liz.
that
I
people
would
know that this
actually, if
exists.
you want to go to our last slide, there's some
There's
pictures.
Yeah. You put in there, thanks.
I did put, so, cause we do cause we're in mobile
You can
settings.
see how it
So,
looks at our.
and I know I have a few, but like our school programs, we did change a lot of things this last year because in the past, our mobile dental equipment is very heavy. Like if you imagine, like we're moving a dental operatory with us. So, we got rid of our compressors because suction, I mean, you have to have compressors to move suction to, yeah. So we got rid of those because we were able to work with NYU and realized we didn't necessarily need those with some new innovative products that exist in the dental world. They didn't require some of those things. And so we were able to get rid of some heavy equipment that I think maybe saved our on-site coordinator, because I think she was going to tell me to kick rocks soon
Right.
because her back wasn't going to take it anymore. So now I just haul the equipment sometimes, but yeah, so we move stuff around, but we go lots of places, and it's
Right. Well, thanks for coming here.
yeah.
We could have set you up to do an inspection of everyone, but it didn't
No.
occur to us.
Yeah, but I think too, if you ever have anyone that you do that is concerned with or is having pain or anything, like, send them our way, even if they don't meet the programs that I have. We have some referral processes that I can get them referred somewhere where they can, get
Got it.
the needs
Great.
that they need. So, because we catch the little corner of Eagle County, little misfit of Eagle over here, but I get phone calls from the other side of Eagle all the time. And even though they're too far away to come see me here, we get them referred. Usually Mountain Family Health over on the other side of the canyon, but we have that system in place, or sometimes it's just a phone call and talking it out with somebody to figure out where to get somebody
Right.
the
Well-
care they need.
Well,
So
thanks, Lisa, and thanks, Logan. for
Yeah.
coming. Sorry, you had a question.
Yeah, I did have one quick question. Can you just give me your opinion about water fluoridation?
I think it's a great thing
Mhm.
when it's done properly.
Yeah, I mean, I live on a well, and my son, who's 5, had several cavities, and I'm like, I do all the things. I was rinsing with the water of our well water, and he was spitting out the toothpaste. Wasn't thinking until I did a tele-oral health appointment at my own program, but that, oh my gosh, I need to be supplementing with a fluoride toothpaste, or I mean like a prescription. Or so, it's changed how we practice and take care of our teeth. But I'm like Lisa said, you have to be careful of how much it is. But
Mhm.
talking with the dentist was promoting it and helping someone in my situation, to prevent more decay. But yeah.
It's when it's done properly. So the good thing too is that it is something that's really heavily monitored by the CDC. So it used to be a range that was recommended for the proper level for water fluoridation. It was 0.7 to 1 part per million. It's been less than 10 years, but we're getting close to 10 years that they dropped it back to just 0.6. They said, we don't need the range, or 0.7. It should be 0.7. And the reason they changed that was because in the US, we do have easy access to fluoridated toothpaste and things like that, right? And mouthwashes and things like that. And so they said, we don't need that range anymore. We're a well-developed country that has easy access to those things. So we need to drop that back to a lower level. So, they monitor those things really, really closely. But the thing with it is that it's such an easy thing because you don't have to change your habits, and it's accessible to anybody regardless of where you live, how much money you make. And when so I can give an easy example of Grand Junction. There's 3 different water systems in the area. Fruta used to not be fluoridated. And if you talk to any dentist in the area, when they weren't fluoridated decades ago, a dentist, they will tell you, they could tell you where a kid lived by looking in their mouth without ever looking at their address, because they would have far more cavities than their counterparts that lived and drank the water and drink from the water fountains at a school in another area.
The dentist there drove nicer cars.
Definitely.
So it does have a big impact. But
no, it's
yeah.
controversial. It can
Yeah,
be
and
a
it can
controversial
be.
topic, but
Yeah.
what
It
we
has
do.
been in Aspen.
Yeah.
We've had people that advocate for us to stop fluoridating our water for decades.
Yeah.
I think around here, I can't remember numbers, but we have naturally occurring fluoride in our water, but it's
it's probably very, very low.
0.03 probably, something like that. So
Yeah,
More
so
of
it's like
on
half
Ajax-
of what it
on
should be.
Ajax, there are a couple of wells.
That have fluoride, more
Yeah,
fluoride there.
I don't think they use those though.
Mm.
From
But the-
speaking to Phil Over under the water department.
yeah, I don't think so either.
But to combat, the sugary drinks that kids drink and all the snacks, I mean, walk down the aisle in City Market and at eye level, you will see the most sugary, dense things that are marketed toward kids. And we talk about healthy beverages all the time and how much sugar in a Capri Sun. It's like 6.5 teaspoons. I mean, that's your daily I think that's your week's allotment for
Daily,
sugar,
yeah.
daily allotment in one drink. So
My feeling
unless you
is
want to
the
change your
poor
behaviors.
Socioeconomic population.
Yes.
Say immigrants, Hispanic population, the fluoride in the water really helps because they can't really afford pediatric dental
Dentistry.
care.
Yeah, true.
So if we want to help all of the population, we really need
It's
fluoridated
equitable to
water.
have. Agreed.
Great.
Yeah,
Thank you. Thanks for that. We
Yeah.
gotta keep moving.
I know. I
Appreciate you coming in.
I could come and talk
Thank
to you.
you. Appreciate it.
I'll just come one day. I'll just do screenings for everybody.
There you go.
Thanks, Lisa.
Thank you.
Yeah. Thank you so much.
Okay.
Wow.
We've got air quality coming on up. This is Natalie. Hi, and Kurt's online. Hey,
Yes.
Kurt.
I am. Can you hear me?
We
Yeah.
can. Welcome.
Excellent. Thank you. Natalie, you want to introduce yourself?
Sure. Hi, everybody. My name is Natalie Sebdos. I'm the Air Quality Program Manager for the City of Aspen.
Great. Welcome. Glad you're here.
And I'm Kurt Dahl, the Environmental Health Manager for the county. Natalie and I are here today. We want to talk about air quality and health impacts with air quality. We've had a lot of discussion. You've seen it in the paper and in news around because of the project going on at the airport. There's been a lot of discussion around air quality. So we wanted to come talk with you about one part of the study that's going on at the airport, which is the health effects side. There's also a study around greenhouse gas emissions. And while those are both related, today we're just going to focus on criteria pollutants. We can come back and talk about greenhouse gas emissions with the board if there's interest. We'd like to pull in some additional staff if we do. So again, today we're going to talk about the background with air quality criteria pollutants that the EPA regulates, that then we work with the state health department to help regulate those. Natalie's going to talk about air quality monitoring and air quality in Aspen. I'm going to give a brief update on the air quality project going on at the airport. There's not a lot to report on at this point, but I can at least give you some updates on where we are with looking at that. And then we'll save some time for questions. Next slide, please. If somebody's there to drive.
Change on our side.
Thank you. Sorry, getting set here. What are criteria pollutants? Well, they're the pollutants that the EPA has set aside for concerns around health effects. And the state health department through the Air Quality Clean Air Act, and then our department helped the EPA to regulate them. They include sulfur dioxide, nitrogen dioxide, carbon monoxide, lead, ground level ozone, and then particulate matter, in this case, PM10 and PM2.5. Next slide.
I have a comment. Ozone is usually an EPA listed pollutant.
I'll talk a little bit more about ozone because there's good ozone and bad ozone too, right? So that's an important piece. So sulfur dioxide is a common byproduct from burning fossil fuels. Most of the time we see this associated with power plants, and especially coal power plants. If we think about our neighbors to the north, Wyoming had low sulfur coal, and that was a really important piece for helping to come into compliance with for wild air coal power plants and the requirement around sulfur dioxide. It can cause concerns or issues with irritation in the lungs. So people who have asthma or other respiratory illnesses, their lungs can become irritated. It's also harmful to ecosystems. It's one of the precursors for acid rain. So for that reason as well, it's a concern. Next slide, please. Nitrogen dioxide, again, burning from fossil fuels. In our area, a lot of that can be from diesel cars, diesel trucks, especially if they're not maintained well. Can also come from power plants. Again, the same thing as sulfur dioxide. It creates irritation in the lungs, can be, it's thought to actually help to create asthma in young children. So there's a little additional concern there around respiratory, not just with irritation. And again, it's a precursor for smog and acid rain as well. So those two are concerned for environmental and health reasons. Next slide. Carbon monoxide. So again, when you burn fossil fuels, you produce carbon monoxide, mostly associated with power plants or vehicle exhaust. Also appliances. And then a lot of the concerns that you will hear in our area have more to do with furnaces or appliances where that appliance isn't properly ventilated and you end up with carbon monoxide poisoning. And carbon monoxide itself, it outcompetes oxygen to bind in your blood with a hemoglobin, and so you don't have as much oxygen being transported to your blood, and obviously can even get to the point where it can create death. But even high levels can cause concern for especially people with heart disease, where there's not enough oxygen going around in their bloodstream that can then exacerbate that disease. Next slide. Particulate matter. Most of you are probably familiar with this. As Aspen was a non-attainment area for particulate matter in PM10. Fortunately, we've come into attainment, and Natalie, I'll talk more about that in a little bit. So particulate matter, we talk about both PM10 and PM2.5, and those refer to size. PM10 is 10 microns or less. PM2.5 is 2.5 microns or less. And again, they can get into the lungs, and the smaller the particle size, the deeper it can penetrate into the lungs, causing, again, respiratory issues and exacerbate breathing issues, again, like asthma or other respiratory issues. Next slide. A little more on particulate matter. Again, to give you an idea of size, we have this graph that talks about how the long gray line there is representative of a human hair. PM10 then is the blue dots that are on there. That's the size of that. And then within that blue dot, you can see the little dots that are PM2.5. And in this graph, I wanted to stop for a second and talk a little bit about ultrafine particles, or PM.1 or less. We hear a lot of information. We've seen concerns around that. There are a lot of studies around health concerns with ultrafine particles. And I think the piece to realize here is what we don't have yet is the EPA hasn't split out ultrafine particles from PM2.5, and we don't have a standard to really talk about in terms of how to assess risk. We know that there may be health concerns around it, but what exposure level we have or what could be that would still either be healthy and what the unhealthy level we haven't established yet. So it's really hard to talk around how to address concerns around that when we're still trying to assess the risk. And they're working on that, but I think the important thing is that we don't have that standard. Once the EPA sets a standard, I think that's something we can then talk about in terms of what those mean to our community. In this case, we're still working on the science catching up to the technology, right? The technology has been able to measure these now for a couple of years, but we're still trying to understand what that means in terms of exposure. Next slide. The ground level ozone. So as Dr. Kurt, I think, is who mentioned ozone. So ozone we have both in the stratosphere, which is good because that protects us from the harmful effects from the sun. But ozone at the ground level, again, can exacerbate issues with people who have lung disease or asthma. So the source of ground level ozone, those are really chemical reactions from industrial facility emissions or from vehicles. And then the last one, next slide, is lead. And we're all probably familiar with lead. We have lead in the soil, in the water in places, and in the air in places. Smuggler Superfund site that we have soil, lead in the soil that we're concerned about. And so we've put in protective regulations to make sure that we limit exposure. Lead in the air comes from fuel. And in the 70s, we had leaded gasoline, for those of you that remember. And we phased that out because we found that that lead was airborne and then causing developmental effects and neurological effects in people, and especially in young children. So the level of lead in air.
1984.
Yes. Well, sorry, it started in the 70s, but 84 was the ultimate ban. Thank you. The place that we still see lead in fuel is in aviation fuel. And aviation fuel is not jet fuel. It's fuel for piston-driven aircraft, so pistons, propeller-driven aircraft. So in Aspen, most of the fuel or most of the traffic that we see at the airport is related to jets, not propeller-driven aircraft. And so we don't believe this is a concern, although there have been other airports around the state, and especially in Denver or even in the country, where they have a lot of propeller-driven aircraft, and there's concerns that the use of aviation fuel may be creating some issues with airborne lead. Like I said, fortunately here, we're not as concerned about lead in the air, but we're going to look at that. I'll talk a little bit about that with the airport in a second. And then the last of my slides, next one, please. So it's a busy chart here, and I didn't want you to get lost in the numbers. What I wanted to point out were a couple of things. One, when we're looking at how these are regulated, we have a primary standard and a secondary standard. So the primary standards are all around health and human health. Secondary standards are around ecology or the environment, and those standards in ensuring that we're protecting the environment. And then you see there's an averaging time. So one of the important things when we look at the various standards, was there a question? Or to click? Okay. When we look at these standards, it's over a period of time. So one of the important things when we look at, say, particulate matter, when we're regulating for that, we're looking at a period of time in which that average of the measurements doesn't go above a threshold. So when we see things like spikes, that isn't necessarily a concern or a violation unless it's a very, very excessive spike, because if it averages out under that threshold, we're okay. We see this issue a lot with, I'll pick on purple air. We have some purple air monitors at the county where they display the information that they get out of those monitors in both an instantaneous piece and then also as like a 24 or a 48-hour threshold. There's a number of different ones. And there was a lot of concern from the public where they were looking at the data showing these spikes in the instantaneous, but that wasn't necessarily a health concern when we looked at the overall trend and compared it to the averages here. I think with that, Natalie is up next.
All right. Is this on or?
Yes.
Okay.
As long as it's red.
Oh, yeah. Okay. Just checking. All right. Thanks, Kurt, for providing that background information. So I'm going to jump right in and kind of focus on PM10. That is historically, there have been some issues with PM10 in this area. So I'm going to talk a little bit about our air quality history, some monitoring that we have going on in Aspen today, and then I'll also share some data that we've collected over the past few years. So in the 1980s, for several years in a row, Aspen failed to meet that EPA standard that Kurt mentioned for PM10, meaning that that kind of led to us being designated as a non-attainment area for PM10. Our sources locally of PM10 that led to that pollution problem primarily came from smoke from wood-burning fireplaces and restaurant grills, dirt on roads, as well as vehicle exhaust. So those are the main things that kind of made up our PM10 pollution problem. And what being designated as a non-attainment area means, that basically charged us with developing a plan. So it's called a State Implementation Plan, or SIP. And that is just a plan that outlines, all right, how are we going to deal with this problem and get back into attainment? And then once we do get back into attainment, how are we going to continue to maintain this standard over time? Another thing about Aspen is because of our location sitting in a valley surrounded by mountains, that makes us prone to temperature inversions, which is a phenomenon that can happen in the winter months. And that's when warm air comes in and it kind of acts like a lid and it traps cold air and pollution near the ground. So, you know, that's where we're walking and breathing and skiing and doing all the things we love to do. And those pollutants can't escape because there's that lid. You can see in this photo was taken from Sunnyside in 1985. This is an example of a really severe inversion, and yeah, just a good visual representation of like the problems that were going on during that time. So thankfully, since the 1980s, we've come a long way. So I mentioned our SIP in response to this non-attainment designation. We implemented some regulations really trying to target those main pollutants, which were restaurant grills and wood burning, so fireplaces and wood stoves. So we have some limitations on those now. And we also have some requirements specifically for restaurant grills that require an additional air cleaner. And another thing that was implemented to target this issue was year-round street sweeping. So that helps remove a lot of dirt from our roads before it has a chance to become PM10. This was, you know, obviously a really long journey over a long period of time. So there was a lot of people, and there's a lot of departments that helped make this happen. It's not just the work of the Environmental Health Department and our regulations, but as well as our streets department that does the street sweeping, implementing paid parking and carpool incentives, having different transportation options and free shuttles. All of those things collectively help protect our airshed.
And you regulated restaurant grills, which.
Yes, yeah. Yeah, so I mean, the support of our elected officials to implement these like pretty robust regulations is also how we came to be.
Big difference.
Yeah, yeah. It's a big source.
The move to electrification will make the next step, I think.
Yeah, absolutely. Yeah. So officially we were listed as back in attainment in 2003, and we have been able to maintain that till today. So I love this before and after picture because it's just a really good visual of how far we've come, and you know, we should be really proud of that. All right, so now that we've kind of talked about our history, I'm gonna hone in on the kind of types of monitoring that we are doing currently. There's a couple of different types of air monitoring equipment, and I'm gonna go over the pros and cons to both of those. So monitors are considered regulatory grade, meaning that they meet EPA requirements for scientific accuracy. They also meet the requirement that it has been imposed upon us as a former non-attainment area by the EPA to continue monitoring. The downside to monitors is that they're very expensive. So the initial cost of this equipment can be, you know, tens of thousands of dollars. There's also an ongoing cost that it takes to maintain them. So staff time that, you know, for us to perform quality assurance checks on the equipment and make sure everything's working. We also spend quite a bit of money on air quality consultants, and they help validate our data. And then they also perform quarterly audits on our equipment. So we make sure that everything is working properly. On the other hand, we have sensors, and sensors are, the advantages of sensors is that they're much less costly. They're also a lot easier to operate. So pretty much anyone can purchase and operate a sensor. You don't need a lot of expertise to operate something like this. The downside is that because the data that's collected isn't validated, it's not considered, you know, scientific, and it's difficult to use that kind of data for any modeling or forecasting. So here in Aspen, we have both monitors and sensors. So our monitors are represented by the blue dots on the map here. We have a particulate monitor that's located on the roof of the yellow brick building, and that monitors both PM 2.5 and PM 10. We also have a regulatory grade ozone monitor that is located in the golf pump house at the parks offices near Cemetery Lane. And additionally, Kurt had mentioned we do have some purple air sensors. So in the top left on the map, you can see a couple of green dots. Those are actually our city purple air sensors that we purchased and put at the Mountain Rescue building. And then you can see there's some other green dots on the map. Those are additional purple air sensors throughout town that are owned and operated by private individuals. So I just wanted to kind of include those on here so you can see kind of this network of air quality monitoring throughout town and where those things are located. Pitkin County also has a purple air sensor that is kind of mobile. So when we think about purple air sensors, and ours specifically measure only PM 2.5, that is typically what we're concerned about when we have wildfire smoke events. And so having that, another benefit of sensors is they're a lot more mobile and easy to deploy. So if there was a wildfire smoke event in a specific area that we wanted to get some information about, we can deploy a sensor, much more easily than we could do any real monitoring. Okay, so now that I've kind of gone over where our monitors are, I'm going to talk about how we got there and why we decided to put them in those locations. So one thing I wanted to just kind of cover as well is we're talking, the type of air monitoring that we're doing is community monitoring. So we're really just trying to get a general representation of the air in Aspen. We're not looking to capture any one specific source. This is just a general representation of the air in Aspen. So we look at a lot of different things when choosing a site for a monitor. Some of those things are purely logistic. We need internet, we need electricity, we need enough space for the monitor and all of the equipment that goes along with that. We also want to make sure that it's secure because it is very expensive equipment, so we don't want it getting tampered with or damaged. We want to make sure it's safe for staff to access, so any electrical and any ladders and things like that, we want to make sure is safe and up to code. It's not, government buildings tend to be very ideal for monitors just because we know that we have long-term access to the space. We know that it's up to code. We have some control over the space as far as the temperature and things like that. And if we need to make any adjustments to the space, we can do that. So it doesn't have to be a government building, but they tend to provide a lot of these benefits. Some other things that we look at are based off of siting recommendations from the EPA. So we want to make sure that the airflow is unobstructed, meaning you don't want like a really tall building right next to where you're pulling in the air because that can kind of block airflow. Similarly, you wouldn't want like a really tall wall of thick trees. And then, like I mentioned, because we're looking at community monitoring, we don't want to place our monitor right next to like a chimney that's just blowing smoke all day because that's going to skew our results and not be a good indication of what's going on in Aspen overall. So I included a picture of our ozone monitor in the pump house, and then the picture on the right is our particulate monitor, which is there on the yellow brick building. So what do we do with all of this data that we collect from our monitors? So a couple different things, I think, other than the programs that we provide that protect our air quality, I think one of the most important services that we provide to the public is providing this current air quality information live on our website. So we have that information available in a couple different forms. We have the hourly averages of the 3 different pollutants that we measure, which are ozone, PM 2.5, and PM 10. We also have our current air quality displayed in the form of an AQI. Which is the air quality index. And that is just a scale that is used to measure the level of air pollution. And more importantly, it connects the level of air pollution to potential human health effects. Our AQI is calculated using the data from our 2 monitors. So our purple air sensor data is not included in this. That's separate. And it's also calculated as what is called a nowcast. That's basically just a fancy way of saying it's not a forecast. So this is what's happening now. A forecast is what the air quality is going to look like tomorrow. Yeah. So how do we measure up? I'm happy to report that we measure up pretty good, and our air quality remains in that good or green level on the AQI scale most days of the year. So you can see that well over 300 days of the year, most years we are experiencing good air quality overall. We occasionally see days of moderate air quality. That is usually the result of elevated levels of ozone, which we sometimes see in the summer months. I'm going to talk a little bit more about ozone in a second. We can also see moderate days of air quality due to PM 2.5, and that is typically a result of wildfire smoke events that can be produced locally. So we've had some local fires like the Grizzly Creek fire that have, infiltrated the Aspen airshed, and we've had some moderate and unhealthy days from that. And then we also have experienced some days where we have moderate air quality due to a wildfire that's really, really far away. So like Canada or California. So those things can travel pretty far distances and affect us here too. We very rarely have days, as you can see, where our air is in the unhealthy category. Even the unhealthy for sensitive groups category is pretty rare. The last time that we had unhealthy air was in 2020, and that was due to the Grizzly Creek fire, smoke from that fire. All right, so I'm going to talk more specifically about ozone now. And so I had mentioned, and Kurt talked a little bit about ground level ozone as well, which is what we're talking about here, not ozone up in the atmosphere. So ozone is a little bit different than some of the other pollutants. It's what we call a secondary pollutant, meaning that it forms in the atmosphere. It's not directly emitted from any one source. And so why we tend to see elevated levels of ozone in the summer is because when you have the precursors, which are nitrogen oxides or NOx, and volatile organic compounds or VOCs, when you have those precursors, they interact with hot weather and sunlight, and that can form ozone. So typically we see elevated levels of ozone in the summer. On the western slope, the biggest sources of those two precursors are going to be oil and gas drilling, motor vehicles, as well as trees. Trees actually emit a large amount of VOCs. We have been monitoring for ozone in Aspen since 2009, and to date, we have always maintained that standard set by the EPA. So the graph on the right is showing that blue line is the standard set by the EPA, and then you have our yearly numbers there, and we're well within that, that attainment status.
So the EPA number is the attainment status, meaning anything above that's bad.
Yes. Yeah.
Anything below it's okay. So if you're walking in a forest and you smell pine scent, that's the VOC coming from the terpenes in the conifers. Is that right?
I believe so. Yeah. It's interesting because obviously trees are like part of a very healthy environment. But yeah, so VOCs, any aromas or scents or things like that are actually VOCs. So like scented candles, like essential oils, all of that is VOCs. So
So if you smell, you're on the highway and you smell something that smells like gasoline or, some sort of fossil fuel, it might be hard to identify whether it's the airport unless you're right there by the, the warm up area.
Yeah.
Or on the highway with diesel or whatever, you can smell, and those are the VOCs.
yeah.
Not necessarily bad for you, or how do you?
I mean, VOCs are not a criteria pollutant. I think just like with everything in small amounts, I don't think there's a major health concern, but there isn't really like a standard that we have for VOCs that we can measure against. So I can't really say what amount of VOCs is okay or not.
It's just kind of interesting that the sensor built in our sinus doesn't seem to reflect the danger then, while the other things do.
Yeah.
Interesting.
In the pine forest, the VOCs are terpenes, as you
Right.
say, are going to make turpentine. In low amounts, apparently, that's good psychologically to go for a walk in a pine forest. Low amounts.
So I can attest to that.
Yeah.
We may have talked about this, but ozone is we all know ozone's good at filtered, but
Yeah.
like a ground level formation of ozone, is that factored into one of those two, the P2 or the P4, what was it? That you track? Or is it just
Um,
tracked separately? There were 3 factors that you tracked.
Oh,
that put it
okay.
down
And
to
then
the
PM10.
index
Yeah, we just track, ground level ozone on its own.
on it separately.
Yeah.
Okay.
Yeah.
So if you do smell VOC, say you're on the highway in the vicinity of the airport and you smell whatever it is, those are VOCs that in combination with the ultraviolet light can become ozone.
Correct.
So if you smell VOCs like that, you're probably in an area that could be producing ozone, and the ozone is measurable and it's potentially dangerous.
Potentially, yeah.
Okay, so the VOCs are doing their job there if you can smell them there. You just can't smell ozone, I guess.
Yeah.
Thank you. Trying to sort that out.
And you have the VOCs from diesel fuel too.
Right, right. Okay, thank you.
All right. Okay, so now I'm gonna get into our PM10 data specifically. We talked a lot about PM10 already, but that is going to be anything between 10 and 2.5 microns in size. The reason that PM10 was designated as a criteria pollutant is due to the small size of the particles and the ability to pass through the throat and the nose and end up in our lungs, and that's where it can cause damage, especially for people that have asthma or lung or other heart conditions. Our local sources of PM10, again, are going to be dust, smoke, some natural sources like pollen can also contribute to PM10 levels here. And we have actually been monitoring for PM10 since the 70s, and that is due to our historical, issues with that particular pollutant. And we have been in compliance with the standard since 2003.
Question again.
Yeah.
Pardon me. Did you have a hand up?
Liz did.
Liz did.
I
Oh,
gasped.
You gasped. She raised her hand, you gasped. Okay, thank you.
What do you make of the trend, the upward trend?
Yeah, so I looked into what day in 2023 that was. I think it was like December 18th was when we had our highest 24-hour average. There wasn't any notable event that day, like there wasn't a wildfire or anything, any notable event that I could tie it to because, it's December and it's the winter.
Wood smoke?
Fireplaces, no?
It could have been wood burning, it could have been an inversion, but I can't say for sure what the cause of that was.
So each of those numbers represents just a 24-hour average on that day, on December 18th, right?
Yes, so
Wow.
that was the highest 24-hour average in 2023, which just happened to be on December 18th.
Okay.
Yeah, that year.
So the other numbers are reflecting the
Highest.
highest day of that year.
Yep,
Not necessarily December 18th.
correct. Yep.
And they represent a 24-hour average.
Mhm.
Well,
Yeah.
if you get up in the morning from about 7 to 10, with people driving more at that time than at midnight, which is also averaged in, they will be higher in the morning.
Yeah, that's a really good point. And if you do look at our website at the individual pollutants, sometimes you will see spikes throughout the day. But what we're really concerned about is that 24-hour average.
So if we're burning natural gas, whether it's stoves or cooking appliances, outdoor heaters, those would be measurable, I guess, through ozone produced. You can smell it, but once again, it's a VOC, I guess.
Yeah,
pollutants.
I'm not sure.
Okay, it'd
sure
be
about
interesting to be able to monitor that,
Yeah.
I think.
This graph would not reflect, let's just say there was one wild card day in December in 2023.
Yeah.
It's showing, wow, 2023 was high, but what if the entire rest of it was a lot lower than the other? So it's
Yeah.
not really reflecting.
Right.
Yeah,
It's
this
just
is
a
just like a
high.
very point in
It's a peak.
time.
Yeah.
And that could be a
Do we have
temperature
information
inversion.
on like annually and how it
Um,
fluctuates? and-
Yeah, like that's kind of
Mhm.
why I wanted to show the AQI because the AQI graph shows like, yes, like December 18th might have been really bad, but like overall that year had like 350 days of good
Right,
air quality. I mean, we have much more detailed data for like every minute of every day, but I wasn't going to talk about that.
It's fair.
Yeah.
Have you looked at any 2024 data in this PM10 area? What's our?
That's a good question. I don't know what our highest PM10 for this year has been. We usually look at, so our consultants do most of our data analysis, and they usually at the end of each year, they send us like the previous year's report with our standard summary showing us, you know.
It'd just be interesting in this case because December 18th, the end of 2023 had such a high reading. It'd be interesting if that is carrying through into 2024.
Yeah.
I guess we'll find out.
Yeah.
That we did they did a controlled burn, Forest Service did. I'm trying to remember when they did it up in Hunter Creek. But it created a river of smoke flowing down right over the top of Hunter Creek, almost on the same track. You could see this. If you took a
Yeah.
photograph from Aspen Mountain, you could see the smoke just pouring into town.
Yeah.
And I was wondering, what date was that?
I mean, anytime, that's why I couldn't really trace it to anything, because anytime there is an event like that, like we record that, that way we can go back and be like, whoa,
So you'll
like
know
what
if that
happened
was-
in April? And it's like, oh, there was that fire.
Got it. Okay.
So yeah, I couldn't, it doesn't mean there wasn't a prescribed burn that caused that number, but I didn't note it.
Right. I have a question just regarding the comments we hear. Of course, we've got an airport that is a
Yeah.
super busy airport. Regardless of what happens to it going forward, it's still going to be a smelly, busy airport. Pretty much regardless of whatever comes down. We have complaints from Buttermilk, the base of Buttermilk and up on West, and sometimes all the way in town. People think they're smelling the airport. They could be smelling the highway. It's hard to tell unless you can distinguish Jet A fuel from diesel from regular unleaded.
Sure.
And maybe some people can. The question is, do we have to worry about the kids at Buttermilk and the volume of exhaust that they're perceiving from the airport runway when planes take off?
So, I don't really have an answer for that just because our monitoring is more located in town. I think in order to like a couple things, in order to really parse out like the source of pollution, you would have to do like what is called a source apportionment study. And that would really be able to tell you like what sources your pollution problem was coming from, as well as, I think more localized monitoring if you're concerned about that area specifically.
Right.
I don't
Maybe
know, Kurt, I don't know
Kurt,
if you.
Yeah, Kurt, I was going to point to you next, Kurt.
Yeah, we'll talk a little more about that
Great.
when I talk about the airport.
Thank you.
I see a trend going up, and even though this is just one day of each year, I think it could be important to look at the average of all the days of each year, so that, because it could be, we're having more visitors, there's more construction. I mean, all of those things are actually increasing that PM10 over time. So I think that's something worth looking at. If you have data that would average it rather than just
the
one day.
highest.
Yeah.
Yeah.
And also looking, I think
Yeah.
you said you started monitoring in 2003.
Well, PM10 has been going on since like a long time ago.
70s.
Yeah.
70s, yeah.
Yeah.
Those fluctuations have been.
Yeah.
often would help
Yeah.
give
Right.
some context.
Yeah.
Dr. Kurt, question?
From my years in Denver, I have some experience in dealing with health monitoring effects, and then with the people coming into the old University of Colorado emergency room. And we use the so-called CAMP station, the continuous air monitoring program of the EPA that subsidizes through CDPHE that was at the corner of National Jewish Hospital, which is Colorado and Colfax. Is there a possibility of getting funding for such a station here in Aspen? A CDPH kind of camp station like the ones in Denver?
I don't know, Kurt. I'm not sure if you're familiar with that, like with that program.
I'm familiar with it. It's certainly something that we could ask, but I think frankly, given the concerns with the population along the Front Range and the air quality issues they have along the Front Range, I think we're gonna have a hard time getting CDPHE to fund something like that here, but we can ask.
It's possible the technology's become better and cheaper since then.
I've also suggested a monitoring station at the corner of stoplight at the corner of the airport, Burlingame and Buttermilk to expand a PM 2.5 monitoring station there, which would take into account both the highway and the corner of the airport, because there's so much stop and go traffic there, particularly in the morning.
Yeah.
Is there an option to add one? There's one, right? The one at the Yellow Brick, is that the only one?
That's the only like particular regulatory grade particulate monitor that we have. Since that specific location is not in city limits, I'll let Kurt kind of answer that.
We have asked for, I know people have asked for this for several years, as long as I've been a commissioner. It'd be nice to know if we can ever do it, or if we are doing it.
Should we run through the last couple slides?
Yeah,
and then
sure,
bring up
let's-
this slide to talk
Yeah,
about
we have to
those?
keep our eye on the clock too. Thank you.
Now I'll move into PM 10 or PM 2.5. So PM 2.5 again is particulate matter 2.5 microns in size or less. And this is considered even a more significant health concern than PM 10 because the particles are even smaller. And so they can reach deeper into the lungs, causing more damage and specifically more long-term health effects. Our local sources of PM10 include motor vehicle combustion and wood burning, wildfires. We don't have a ton of industry here, but wildfires and wildfire smoke infiltration is probably one of our biggest threats as far as PM10 goes. And we have been monitoring PM 2.5. We have been monitoring for PM 2.5 since 2014, and we to date have remained in compliance with that standard. There's a couple different metrics. I have like two tables here on the right that are the different metrics that the EPA looks at, and we are in attainment with both of those.
You know, it's interesting just that our scales are so different. I was looking at that thinking, wait a minute, the 2.5 24-hour average curve is almost the inverse of the one we saw from PM10 through the same period. But I realized that was the peak and this is an average. So it'd be interesting to see the, actual similar scales on these things.
Yeah, and the reason I chose these specific, this is like the standard that the EPA uses to measure whether or not we're in attainment. So I did not choose the 98th percentile 24-hour average just by chance.
Okay. Yeah. See, it'd be nice to be able to compare oranges to oranges.
Yeah, that's a good point.
Well, thank you for that.
Yeah. So I'll just kind of wrap up by trying to kind of bring all of this information together that we've talked about. And really, the most important thing that I think we want to take away from all of this is, we have all this monitoring and this data, but what does that actually mean? And what do we need to do with that? So I think the biggest message that I tell people when I talk about air quality is encouraging people to stay up to date and informed on what their current air quality is and following the recommendations based on the AQI, depending on what the AQI is that day, especially when it comes to outdoor activity, very strenuous outdoor activity or planning an outdoor event. There's a few different ways to stay informed. One is by checking our City of Aspen website. We have all of that live data on there. Another tool and thing that people can subscribe to are air quality health advisories, and those are issued at the state level. Typically, we don't see those unless we are reaching that unhealthy for sensitive groups level or that orange level on the AQI. And those air quality health advisories then get pushed out, and they have a lot of good information. They include a lot of forecasting, so you can plan ahead, and they also include recommendations for outdoor activity depending on, certain groups. And then we additionally push those air quality health advisories out through Pitkin alerts. So if you're subscribed to Pitkin alerts, you will get notified if there's any air quality events going on in Pitkin County.
How often have we done that? Pushed out an alert?
So the last alert would have been in 2021 due to wildfire smoke. And then before that, it was 2020. So we haven't had one in a couple of years.
Usually associated with wildfires then.
Typically, yeah.
Great. Well, thank you for that. Is that it?
That's all I have. Kurt has.
Kurt's got
a little
more.
bit
Got it. Here we go.
All right, thanks, Natalie. wanted to talk a little bit more about the airport because this has been driving part of this conversation. So the airport has convened 2 studies, one for greenhouse gas emissions related to the airport, and the other air quality related to health. And so the airport has worked with a number of groups, including the city and county environmental health departments. The process they're working through is they have looked at hiring a contractor. And then once the contractor is hired, we talk with the contractor about what our desire is, in this case, with greenhouse gas emissions and ambient air quality standards. And then the contractor works on a proposal that comes back to the group and suggests, here's what we recommend in terms of doing monitoring. And so last year, we, as a group, met with the airport, selected a contractor, and then that contractor convened a meeting with the group to do both greenhouse gas emission and ambient air quality standards in May. At that May meeting, when we talked about the health pollutants, we talked about what we wanted to survey for, costs of the study, and the group itself ended up making a recommendation to the contractor that we wanted to see sampling for the criteria pollutants that I presented on, and then volatile organic compounds, VOCs, what you all were just talking about. The VOC component came from complaints from people in the area around what we presume are unburned fuel, either jet fuel, diesel, we're not sure. What we're gonna do is initially we'll do some sampling around that. One of the questions that the group had for the contractor that we're expecting the contractor to come back with is how best to do the sampling for that. Do we try to, as Greg noted, are we smelling diesel fuel? Are we smelling jet fuel? Are we smelling gasoline? Can we situate out all of those in a sample so that we understand what VOCs we're smelling? Our nose is a great detector, but just because we can smell it also doesn't mean that it's a health concern. And while VOCs don't have standards like the ambient air quality standards do, we do have standards from NIOSH, which is the National Institutes for Health, or OSHA, both, that we could reference in terms of an exposure if there were high levels of VOCs, just to understand if there are health impacts. Again, those health impacts would be over a time threshold. So again, it might be like an 8-hour time shift for OSHA or a 15-hour minute, but we'll be able to compare that data. So we've made the recommendations to the contractor. The contractor is now working on a plan that they will come back to the group to propose on how we're going to do the airport sampling. And that will include the site and locations for either air sensors or air monitors. I'm anticipating we're going to see a recommendation of both. Some will be for the pollutants around the criteria pollutants that we don't expect to see high levels of. So say sulfur dioxide as an example. You may see something like a recommendation as a sensor instead of a monitor, just because we may not necessarily need that level of detail. But we want to sample for it. One of the things that we've heard from the community is while there's been a fair amount of modeling done around air quality with the airport, based on the aircraft, the types of emissions coming from the aircraft, as well as a ground operation, and that modeling indicating that some of these are not going to be health concerns. It seems the community wanted some real data to demonstrate that. So that was part of why we're going to sample for all of the criteria pollutants and then VOCs.
Great. Thanks, Kurt. I was going to throw in, we're pushing to electrify all the ground operations at the airport, because sometimes the APUs, the auxiliary power units that keep the planes cool or keep them going while they're on the ground were fuel. Based with fossil fuels. If we electrify those, it makes a difference. Electrifying tugs and all that stuff as well. The thing I was wondering is, I'm sure we've got somebody who understands what operation of an airplane engine at this altitude does and how much unburnt fuel there is. I think we're operating, say, in the summertime at this elevation or versus winter, you have a certain percentage of fuel is unburnt. And Dr. Kurt may have studied that or know that in your history with the military, but it's a problem.
At the Denver airport.
Sure. Yeah. So I think we could hopefully our contractor will, or you, or your department will have some data on that can help us understand just how much unburnt fuel there is.
The pollution
And that's the
occurs,
goal.
Not on the runway itself, but at the end of the runway where they're taking off, the vortices go back more than 1,000 feet.
Right.
So there's a monitor that was put on a kind of a chair outside the airport fence was knocked over by the vortices
Right.
effect of the aircraft engines when they blast off. And it went into the Buttermilk parking lot.
Right.
In other
So
words,
you get a
we're
plume.
concerned Not so much about the middle of the airport, you're concerned about the end of the runway.
Right. Right.
And so with the mixing of air, Greg, that's one of the goals, is to understand what the VOC levels are. And then specifically, you know, where we want to be able to identify, is it Jet A that's unburned? Is it diesel? Is it gas? Those are all part of the goals of the group. So,
Right.
so the contractor's got to come back to us. They haven't reconvened a meeting with the proposal for where they're going to set everything up and the various monitors and sensors. We were hoping that they might already have had that data to us by the time we had this presentation, but they don't yet. So the other important thing that again, I think it was Dr. Kurt brought up that we haven't discussed, it's been put on the shelf until we get the airport piece going, is the acknowledgement that when we talk about air quality, it's not just about the airport, but if we're thinking about health, we want to think about all the components. And so the highway being right there is another major source of air contaminants based on the samples or the information from the criteria pollutants. A lot of that came from vehicle emissions as well. So we want to look at adding on to this airport study with some additional sensors and monitors across the highway to really assess the overall air quality that's going on in the area. And I think that gets to a little bit of what Dr. Kurt was talking about, with particulate matter being one. Right now, the goal is to get the airport study going. And then the hope is that we'll talk with the current contractor about their thoughts of putting some additional sensors and monitors up across the highway that then will help us to assess the overall air quality in the area and how it might be impacting the residences in the ABC Burlingame, the new development that the city has at the the lumberyard, sorry. So that's coming. We're waiting until this airport study gets going, and then we'll have the contractor look at that. The reason I mention that is once we have that information and we have an idea of what that program could look like, I would like to come back to the Board of Health and present on that, ultimately looking for a recommendation from the Board of Health that then we could take to the Board of County Commissioners, who obviously, and potentially City Council as well, that ultimately would help to fund this. But so that'll be a forthcoming piece, but I think it's an important piece to talk about when we talk about air quality in the area, not just the airport, but everything else.
Right. Airport and environs. Thank you. Any questions for Kurt? Other comments, questions? Kurt, thank you for that. Natalie, thank you. Kurt, the only question I had was, how soon do you think this contractor is going to deliver something?
I just saw, I'm sorry, I'm on vacation, so I'm looking through emails. I'm in California right now.
In the Redwoods.
Actually, Morro Bay in Central California. So we were at the Hearst Castle yesterday. Anyway, I saw where the contractor has started getting back information on the greenhouse gas portion. So I think it's pieces of this are now incoming. We had anticipated they would have it, so I'm guessing in the next several weeks I'll have most of that information.
Right. Well, let's put an electric burner under them.
Sounds good.
Sir.
Thank you, guys.
All right, thank you
for coming in. We're going to keep moving. We've got 15 minutes left. Round robin, if anybody has anything else they want to bring up. I have one topic, and then we just have to discuss our next meeting, October 10th. And Kim, did you just raise your hand? I thought I saw movement. No, wasn't you. The only thing I wanted to bring up is I shared an article recently. It's a Rolling Stone article about how contraband pills of various sorts are, when they mix fentanyl in with them, they don't blend it quite well. So one pill, if you break the pill in half, one half of it can kill you and the other half would just give you a nap. because it's not blended properly. So when they're making these pills, that's why you get lethal results.
You
And
should just blend them more so that it kills.
well, they should
everyone.
blend them better, right? Well, but
Don't break the pills in
don't
two.
break them too, but this whole article
Oh, I
was
see.
about how Snapchat is the perfect medium for drug dealers because any messages just vanish. And they attributed one Snapchat, feed and a dealer in Southern California toward the deaths of something like 700 to 900 people.
Whoa.
And it strikes home because we're going to a memorial service tomorrow. Thanks, Tori. There's a memorial service tomorrow for Bailey Caddo,
Yeah.
who overdosed accidentally in New York. Not sure quite what on, but I think it was fentanyl, but we don't know how it was delivered to them.
So sad.
Unbelievable.
It's a tragic thing, and I can think of other kids in the community too. It's not an isolated incident, and so I wanted to draw our attention to it because it was just so crazy to think that there's social media platforms that are just perfect for surreptitious activities that could kill people. I don't know what we can do or how we can publicize that. I just thought it was interesting reading.
It's a great segue into social media.
Yeah.
Oh, that's what you were going to do. Report director's update.
I just wanting to draw some attention to another Surgeon General's been busy. He called for a warning labels on social media by writing an op-ed piece in the New York Times. If you haven't gotten a chance to read it, it's a great read, not very long, but just really draws the connection between social media among young people and the mental health crisis that we're currently undergoing, knowing that there's a direct connection there. Science hasn't come to share exactly what percentage and exactly what, but the goal is, we need to act now. We know enough to put the warning out. We know that 3 hours or more a day on social media for adolescents doubles the risk of anxiety and depression. Almost half of adolescents say social media, when they use it, makes them feel worse about their bodies. There's the Surgeon General is saying that a warning label would just get out there and really indicate that social media has not been proved safe. We know that warning labels on tobacco have worked to increase awareness and change behavior. And so, this is not the one solution to this problem, but could be a part of how we could draw more attention to this issue. Additional strategies that are being discussed right now are legislation from Congress around social media platform reforms, and that the public should know what they can do to engage in safer practices. So things like, in your home, if you've got any young people around, and I would argue this is probably great practices for everyone. Those phone-free zones around bedtime, meals, and social gatherings. We know that if your kids who have phones with them in the bedroom are staying up all hours on social media, which then they can't get enough sleep. We know adolescents need a ton of sleep, so it's part of this cycle. And then another option is just to wait until after middle school for access to social media. So waiting till kids are in high school, they have a little bit more of that frontal lobe development and functioning, and can put it into a little bit more perspective than when all of that is developing in middle school. So, thanks for suggesting that, Greg, as something to bring up to the board.
Yeah, thank you. It says half of adolescents say social media makes them feel worse about their bodies. That to me, I think has an incredibly, what can you say, consequential, effect. The effect could be life-changing in so many ways.
I like the way the Surgeon General did it. I mean, are we going to wait until we have tons of bodies of research and so many X amount of articles that proves this? Or can't we just put out a warning and say, hey, we know that this might be coming? I mean, learning from tobacco, and it's great.
Well, and I'd also say it's pretty obvious to any lay person.
Yeah.
Right?
Right.
I don't really feel like I need proof.
Right.
Right, yeah.
Isn't the Aspen School District one of many across the country that are banning cell phones and?
They're working.
Mhm.
I
Yeah.
think.
Controllers,
Yeah. I don't know.
controlled devices or something.
Hasn't Congress tried to ban TikTok?
Yeah.
I'm not sure for
And they're
that
being
reason,
sued-
but it'd be
they're
great if
being
they did.
sued by the Chinese government.
Right, right. Ah, well, yeah, imagine a world without social media. I can.
Wasn't that long ago.
I know. Anything else, director's report? That's it. Our next meeting is on, did we say October 10th? Is that
Mhm.
what I said? Do I need a motion to adjourn?
So moved.
Some, Dr. Kurt,
I can second now.
John, oh, John can second now. Hey, he has a reason to be here.
There it is.
All in favor?
Aye.
Thank you all for coming. That was great. Well done. And I've got 6 minutes before my next meeting, yeah.
Well,